Come on in. Hello.
Morning, Dr. Somani. Could you tell me more about yourself?
I'm Dr. Somani, and I have been an ID specialist since I finished my training back in 1998. I've been at NUH since the end of 2018. I was here for about over a year right when COVID started.
So what is infectious diseases?
Infectious diseases is a specialty that people really didn't know about until COVID. But what it is learning about all the different pathogens. So there's bacteria, there's viruses, which I think now everyone knows about. There's parasites, fungi, all different types of pathogens. And we live with them all the time. They are generally our friends, but they can cause diseases. And so infectious diseases is the study of those types of infections and how we can best treat them.
So Dr. Somani, why do you choose to specialize in infectious diseases?
I was always interested, and I always did a lot of jigsaw puzzles when I was younger, and I really like mysteries. And infectious diseases is basically like that. It's trying to figure out what is causing a fever or what is causing an unexplained high white count. This was back in 1984, and started hearing about this new disease where healthy people were getting very atypical, opportunistic infections. So they were getting infections that would only normally be seen in a very elderly person or in a patient who had no immune system. And that ended up being what we now know as HIV/AIDS. So I became interested in how the immune system, functions and regulates and prevents infections, and the types of infections you see when patients have immune deficiencies.
Could you explain more of the work that you do?
Sure. So I think, again, ID doctors tend to be doctors, which is why the public doesn't know that much about what we do. Doctors will call us to help them manage certain types of patients. So patients who have fevers, patients who may have a high white count that they don't understand, patients who have positive blood cultures where there's some bacteria growing in the blood. And so we'll go in and we'll help the doctor treating their patient for that specific problem. So we're not that well known to the patients other than those few visits that we make when we're helping manage their care. So besides actually seeing patients, infectious disease doctors do a lot of behind the scenes work. You can consider it sort of a quality of care type of work. So within the hospitals, we often help monitor and make sure we're using our antibiotics appropriately. Other things that ID doctors are involved in could be preventing surgical infections, so we help write the guidelines for what's the best antibiotics for patients to get prior to surgery. And we also work with infection control quite a lot. Some of what we do is help decide what types of disinfectants to use, how we can minimize hospital-acquired infections. And of course, with COVID, I think people are now aware of the importance of personal protective equipment for staff. Part of that, in terms of staff safety, besides infection prevention, is making sure staff are getting vaccinated appropriately before their work so they can be protected.
So what kind of patients do you see in your clinic?
So as I mentioned, here at NUH, I mainly see patients that were seen in the hospital, and they're coming in for follow-up. So they may have gotten 2 weeks of IV antibiotics in the hospital, but then we're continuing oral therapy. So I'll see them while they're on the treatment to make sure they're doing well, that they're improving, and they're not having side effects. I also will get to see patients that are sent from other doctors, either from the emergency room or the polyclinics, and they may be referred because they have fevers, or they went and presented with diarrhea, let's say, and then something shows up on the cultures and they need to be treated. We also sometimes see patients who've traveled and come back with fevers.
We know you chair a few programs. Can you please share more about the programs?
Sure. So one of the programs is the Antimicrobial Stewardship Committee. It's ASP. All the hospitals in Singapore have it, and most of the hospitals in the US also have an ASP team or ASP committee. The purpose of it is to ensure that antibiotics are being used appropriately. And this has really become an issue because we've had increasing antibiotic resistance worldwide. That means there's bacteria that are normal, even our strongest antibiotics aren't working anymore. And the reason is some doctors, or many doctors, and even patients are using antibiotics inappropriately. So it's a little bit like global warming. Global warming is happening even though people like to deny it. Same thing with antimicrobial resistance. It's continuing to grow, and it's predicted that many more patients will be affected by these resistant bacteria. We create guidelines that are evidence-based, and we also try to work with the doctors to have them use shorter durations and more appropriate antibiotics. People may think that that may hurt the patient, but in fact, patients are getting hurt by having overly broad antibiotics or longer durations of antibiotics that they don't need, because what's happening is the antibiotics can actually kill their normal bacteria, what's now known as the microbiome, and that normal bacteria protects them from the bad bacteria. All hospitals have to abide by PUB regulations and test the water periodically, which our facilities management does. Infection control is also involved in this, and we thought we should formalize the process and have a water management committee. The purpose of the committee is not just to oversee these water checks, but also to oversee the sink maintenance, shower maintenance, and things like that. So all of the things that the water goes through. Another program that I run is the hospital epidemiology program. The hospital epi program does many things. It consists of a team of epidemiologists, and half of what they do is mainly reporting, a lot of reporting to MOH about our resistance rates. With COVID, there was a whole lot of reporting with all our new admissions. A lot of the contact tracing gets reported back to MOH. Some of the other things that we do as well are all of the outbreak investigations. So if there's happens to be a cluster of some type of infection, let's say it's diarrhea, then Epi team will go in and do the investigations to try to figure out where it's coming from. So the other committee that I chair is the Infection Control Committee. And actually, if you put Epi and the infection control nurses together, that's our whole IPT team. But what the Infection Control Committee and what the Infection Control Nursing Program does is really a lot of behind-the-scene things that people aren't thinking about, and in order to keep both staff and patients safe from hospital-acquired infections. So the infection control nurses go around and do a lot of observations, making sure that there's hand hygiene is being done properly before patients are seen by the physicians or the healthcare providers. They help with making sure staff are wearing the proper protective equipment, depending on the type of infection the patient has. They do things like helping procure, the different types of gowns that we need, the different types of hand hygiene products, even what's used in the operating room to help clean the skin before surgery. So the infection control nurses also make sure that patients are isolated appropriately. So sometimes we have patients who may be colonized with a very resistant bacteria, and when they get readmitted, they need to go into an isolation room so that that doesn't spread to other patients.
So, Dr. Somani, what kind of patients do you see in the wards and ICUs?
So when I'm on the inpatient team for infectious diseases, we often see patients who need to be in isolation, such as this room. They could have chicken pox, they could have measles, they could have TB, they can have COVID, of course. Things like that where you need to be in isolation so other staff or patients don't get sick. When I'm on the consult team, we're seeing patients all over, and they could again be in the wards and have, let's say, a bone infection or an infection after surgery, or they could have a Klebsiella liver abscess, and they could have had a transplant and now have a fever or infection from that. In the ICU, of course, we see our sickest patients, and again, we've seen many patients with COVID in the ICU. We've seen other heart valve infections or bloodstream infections, or patients who have meningitis. Sometimes as an ID consultant, we see patients where we do tell the teams that actually this isn't an infection and you need to look for other causes of the fever or the high white count, for instance.
Can you share about the work that you and your team did to keep our patients and staff safe during the COVID-19 pandemic?
Sure, we did a lot of contact tracing, we did a lot of PPE trainings, but when Delta hit, we saw that it was quite infectious, and knowing that we have a lot of open cubicles, we wanted to be prepared when there would be a case of a COVID patient found in an open cubicle. And because NUH has so many different wards with so much different ventilation and configurations, we needed to be prepared ahead of time. So we worked with our facilities management, our air engineer, to go around and understand the ventilation and how the air mixed. So for example, if you're in one ward and there's a patient who gets COVID, does that air mix with where the staff room is or not? And we needed to know those things ahead of time. We developed this hot ward toolkit. So if we did find a positive case, we knew how we could protect our staff, who we needed to contact trace, and also how we would manage the other patients who were in that particular ward.
So what do you love about working in NUH?
I think it's a very dynamic place. Everyone is striving to do their best and also improve their skills. So it's a great team to work with. I get to do a variety of things here at NUH. So in the morning I'll see complicated tertiary and quaternary patients with problems such as infections after transplant or after complicated surgeries. But then I get to go off and also see tropical medicine patients here, which I wouldn't see in the US. In the afternoon, I may have meetings with my ASP pharmacist doing antimicrobial stewardship. I may then meet with the EPI team to look through an investigation that's ongoing, and also work with the hospital leadership and ops on policies that can help protect our patients.
So what makes your job worthwhile?
Honestly, at the end of the day, it's being able to make a difference.
That's beautiful. Thank you so much for your time, Dr. Somani.
Thank you.
See you.